All right, looks like that 27 number is holding pretty steady. So we're going to go ahead and get started. Hello, my name is Camille Hancock, and I am the lead social worker for the New Mexico Family Advocacy Program. I want to welcome everyone here to the 56th ECHO session. NMFAP is a model of respondent parent representation being implemented in the 2nd, 13th, and 11th judicial districts. The program utilizes interdisciplinary teams of lawyers, social workers, and parent mentors that provide high quality representation and the advocacy and support families need for reunification or other preferred outcomes in the child welfare system. My name is Camille Hancock, and we also have Jen Vieira back, and she's going to be our IT support. So thanks, Jen, and glad we have you back. Today's topic is system-based trauma responsive information gathering, and this is going to be presented by Dr. Davis. So a couple of housekeeping items. If you can, please, so that we know who's here and attending, if you could put your name and your email address in the chat box. It is being recorded, and that's kind of like our sign-in sheet. So if you could please do that. There will also be a post-session survey, which is an integral part of our program's data collection and efforts under the federal grant that we have. The survey will only take a few minutes, and we'll post it in the link at the end or near the end of the session. For this session, there is 1.2 general continuing legal education credits being offered by the Corinne Wolf Center for Child and Family Justice. So thanks, Kristen, for that. And the form is located on the program's website, and Jen will put that up as well. There's also 1.25 CEUs for social workers that participate, and you must email echonmfap@gmail.com by the end of the day on Thursday. We'll put that in the chat box as well for you to get your CEU. So without further ado, we have Dr. Davis, and Dr. Davis is a board certified psychiatrist in practice. Kristen, you unmuted. He's been in practice since 1990. He was the supervising child psychiatrist at the University of New Mexico Family Medicine Adobe project. Dr. Davis previously served as the Director of Psychiatric Services for the Juvenile Justice Division of CYFD, and prior to that was the Medical Director for the Children's Community Health Clinic at the Bernalillo County Juvenile Detention Center. Dr. Davis has served as an expert witness on a variety of topics in psychiatry, including adult and juvenile forensic psychiatry, developmental trauma and criminality, and adolescent psychiatric treatment and program design. He continues to teach at the UNM School of Medicine, Department of Psychiatry. So, Dr. Davis, I'm going to let you go, and I will keep an eye on the chat box for you.
Thank you very much. I appreciate it. It's nice to be here. It's nice to see a lot of people that I know from the past and the present as well. So I'm going to say a couple of things about this before we start into it. One is that with regard to questions, try to put them in the chat, of course, but we may address those at the end, unless there's immediate ones that, that just need clarification. But otherwise, I'll try to leave some time at the end, not just monologue for, the entire time. The other thing I was going to say is that whenever you're talking about trauma responsive history taking or information gathering, whenever you talk about trauma, whenever you talk about memory and traumatic memory, it can be a trigger for a lot of people. And so I make every effort not to go into illustrations of certain things, you know what I mean? Because I notice that when I start reading about memory, I become self-conscious of my memory, and it does bring memories up. So I'm going to try to do that. this discussion is more directed at history taking that you might do in your field, whether that's legal or whether that's social. It's not meant to be a therapeutic history taking, which is a different issue altogether, but I'll highlight that as we go. And then the last thing I was going to say is there's really two halves to this conversation, and I don't want one to usurp the other one. The first one is talking about memory itself, how it works, and then how traumatic memory is different than that. And you really can't, without knowing that, you really can't proceed to take a history. And so that's an important background, but it's such a great and interesting topic on its own that I don't want that to usurp the rest of the discussion about history taking. And so I'm going to, whatever happens at slide 24, I'm going to move over to the second half of this and not allow myself to just go on and on topics that might be interesting to me. Let me think here. I'm not getting, for some reason, it's not advancing for me. Oh, there it goes. Okay. So these will be on the slides that you got, which you can get a copy of. I just put them up there because this is a great thing to read about. And The Body Keeps a Score by Vander Kolk, which a lot of you have probably read, remains, I think, one of the greatest books on trauma and trauma history taking. Yeah, I mean, I know there's more, and I know that other people have other preferences, but that remains like an iconic kind of book. And then the other two are two of many, because a lot of this memory, traumatic memory and history taking, gets involved in legal proceedings with children. And how good is children's memory? What do they remember? How do they remember? How long do they remember? All those questions, which are all fascinating. We won't answer today, but that's why I included those other two books, which you can tell are kind of dated, but nevertheless, they're kind of like some high marks in the field. I'll put it that way. Okay, memory. I said at its simplest. I didn't realize I put that on there, but it's a very complicated topic. And probably this first entry, like memory components and encoding, that's probably the most important thing to understand about memory in general, is that memory, by remembering things and by storing things in memory, you're not remembering the actual incident. This is obvious if you think about it, but it's important. It has a big effect on the way you try to remember it. And so when you perceive something, whether it's auditory, visual, olfactory, somatic, tactile, when you perceive that, the mind turns it into a construct. And that construct is what is saved. And then when you remember it, you are reconsolidating that construct. So you're not really remembering the thing itself. And it's important to remember, like, how it's stored makes all the difference in how it is retrieved. For example, a child's age and knowledge has a huge import as to how something is stored. If I don't have a container or a context for certain things that happen to me, then I don't really remember them, or remember them in a different kind of form. If you know what I mean. It's like, trying to remember a French phrase when you don't know what it means. All it is noise. And for children, if I remember my childhood correctly, I didn't have any idea what was going on most of the time, or what adults were up to, or what they meant. And so that storage is important. The storage is a combination. The storage meaning there's a temporary storage where they combine, sort, route these kinds of memories, and that usually happens in the hippocampus, which is what will always turn up when people are talking about memory. It doesn't really stay in there forever, although some of it does. And then somehow The hippocampus decides whether this is working memory, which I'll talk about, short-term memory, which I'll also define, or long-term memory. And it's probably based upon the emotional valence of the whole thing. You know, it's like we all know when we read a phone number that it's not important to us personally, unless it's, you know, unless it has emotional content in itself. So the storage and the routing temporarily is what happens in the hippocampus, and then the retrieval is a reconstruction of that from associations and neural networks, and those come from all over the place. These memories, which are stored at one time, they are what is called consolidated in slow wave sleep, like 3 and 4 sleep. And during that consolidation, that the connections are strengthened. Somehow the memory is codified additionally, is translated into a construct that is memorable and it's located somewhere. That's why, you know, not getting enough sleep or not sleeping after certain events will alter the memory of those, and they won't be consolidated in the same kind of way. Not all the memories are consolidated during slow wave sleep. How the mind does this and how it knows, like I said, is probably emotional valence of the memory, but some memories are dismissed, and some memories are additionally activated and reinforced. And that process of consolidation doesn't always apply to post-traumatic memories, meaning a very emotional traumatic memory, like say you take a car accident or any kind of emotionally strong event, probably doesn't get consolidated in the same kind of way. It probably doesn't get stored in the same kind of way, and it's not the same kind of memory. Of course, memory is not one thing. There are various types of memory, and when you're taking a history, you want to keep this in mind. You're asking, usually, you're asking for episodic memory, meaning a memory of an event, or a semantic memory, like a retrieval of a fact. Those things are types of long-term memory. In fact, explicit memory, declarative memory, conscious memory, those are all in some sense synonyms, and usually they are intentionally stored, and they're always intentionally recalled. So we have some choice over those, which is a little bit different from traumatic memories too. We don't always have as much choice over those. The other kind of memory is obviously an unconscious memory. It's also called implicit or procedural. And those can be things like motor memories, like riding a bike, driving to work. We all know how we'll get in the car and we don't even remember how we got there. And sometimes we're not even going to work. We're going to the store, but we go to work anyway. If you know what I mean, those procedural memories drive a lot of our behavior, and they're unconscious. And they're probably unconsciously stored as well. Something like tying your shoes is stored because you repeat it a million times over the course of your childhood. And it's just there. And we didn't intentionally remember it, it just happens. And a lot of those are stored differently in motor control areas. But it's important for childhood that early caretaking is unconsciously recalled and re-experienced. And so a lot of things that happen to us have an influence on our future behavior. And a lot of that is because of memory, but a lot of it's not conscious. So early caretaking is unconsciously recalled and re-experienced in some sense. Or a lot of, I think, our biases or predispositions have a lot to do with unconscious memories of early childhood. Now, I know I'm talking like a psychiatrist, but I swear this is true. That a lot of what we do is determined by very early events. Conditioned responses are also a kind of memory, you know, or just an intrinsic fear of certain people, animals, fear of animals is a natural childhood thing, but an event or an experience with an animal will condition people. And those conditioned responses, a lot of them are, how can I say, physical. They have a lot to do with being aroused or disgusted or frightened by certain kinds of things. Those are also a kind of memory, and they're really an implicit memory. And then autobiographical memory is the sense of ourself over time. And by that, I mean, like, we have all these memories, hung like, ornaments on a Christmas tree, but the tree is this sense of our core self, all these things that happen to us over time. That's what autobiographical memory is. It's also kind of a form of memory in itself. We all have the experience of being the same person forever. I sometimes feel like I have the experience of just being a 7-year-old kid. And you don't recognize, that time has gone on, where that core sense of self remains very much the same. I won't stay on this, but I just want to say a couple of things. You notice out of that big category of memory, almost all of it that we're interested in today, and usually what we're talking about in memory, is a form of long-term memory. Short-term memory and working memory are two things I need to say something about, but I'll stay on them shortly. Short-term memory is if you need to remember something like a phone number or one of those codes that they send you for logging into a website. You need to remember it just long enough to re-enter it on your computer, and then you forget it. That's short-term memory. Working memory, which is not even listed here, working memory is the ability to retain information long enough to manipulate it. I always think of it like, if you're looking at a mathematical equation. I know we're not all doing algebra here, but nevertheless, the metaphor still works. You have to remember what the first half says before you get to the second half. It's the same thing with long sentences. You need to remember what the first half of that sentence said, even if we're speaking it, so that we can finish that sentence. That's working memory, and working memory is the retention of stuff so you can manipulate it or recall it for an ongoing experience. Long-term memory, like I said, has conscious and unconscious memory. And conscious memory, you realize we're getting to the point where we're after is like, we're asking about people's historical memories themselves. That's usually conscious memory, a long-term memory, and it's about events that happen to you. Or a general knowledge of the world, if it's semantic. Developmentally, conscious and unconscious memory, explicit and implicit memory, they have different courses. Like I said before, implicit memory is present from very early on, very, very early on. It seems to be almost there from the point of birth, that sort of implicit memory. But like I said before, because when you're a newborn, or even when you're a 3-year-old, you don't have enough experience to categorize the stuff. So it's present in a very amorphous, unconscious kind of form. If you know what I mean, it doesn't have a semantic correlate. You can't reduce it to words or talk about it. Explicit memory also developed, and explicit means conscious memory, also develops earlier than most people realize. And, you've got the functioning capacity for it between 8 and 10 months of age. And especially if something happens twice, your memory retention of that is doubled. It doesn't mean, a lot of times we think that young children don't have long-term memory because we can't remember what it was like to be 3, much less a newborn. But that's not necessarily true. They will retain memory, young children will, and they can talk about it for a matter of weeks to months afterwards, and it's increased if it's repeated. So The question is, when you're taking a kind of memory, taking a kind of history, or especially a trauma history, you need to know what you're taking it for, like what's your purpose in taking this history. Clinicians of all kinds are going to use it to make a diagnosis. They're going to use it to treat a patient. They're going to use it to get a clear picture of who this person is. But it's a clinical reason. And then also clinicians are going to take that same history and use it if they're going to try to address the trauma or the condition that results from the trauma, whether it's depression or anxiety or whatever. Legal system is taking a history for culpability reasons. They want to know what presented in court, who's at fault. And insurance companies, of course, take histories so that they can deny payment. That's a joke, but you all know what I'm talking about. Historical memories. When we're talking about taking a trauma history, we're talking about, like I said before, we're talking about conscious or explicit memories, and we're talking about episodic things that happen, episodes in our life. Not the former, not unconscious memories. But as we move into thinking about traumatic memories, these categories aren't that clear. And traumatic memories, because of the nature of how they're stored, do not really fall into those categories of conscious and unconscious, explicit, implicit kind of memories. They seem to be remembered differently. And I want to point out earlier, I meant to say this, that all the discussion of memory, when we talk about everything from encoding memory and retrieving memory and storing memory, all those are metaphors. We really don't know what's going on. Because we're using the only tool we have to investigate is our own minds, and we're investigating things that have to do with our minds. It makes it hard to see the back of your own head. But also molecularly, at the cellular level, we don't really know how a memory is encoded. We know that it makes a mark on a neural network, and that mark is durable, that it has to stay, and that we somehow can find our way back to that when we have to remember it. The point about episodic and explicit memories, which are long-term memories, those oftentimes get narrated. And the minute you discuss a historical memory, or the minute you recall it and tell someone, it has become a semantic memory as well. Always remember that. So simply talking about the memory has converted that memory somewhat. Memories are labile, meaning they're not permanent in their permanent form, except for some memories, and some of those being traumatic memories. But for the most part, by virtually talking about a memory, we have changed that memory, and in some ways, we've loosened that memory. Because to talk about it means that you have to re-remember it now in a verbal fashion, and that changes the memory. It's one of the bases of how you treat traumatic memories. Is anything you can put into words has less potency. I don't always mean that, but I think generally that is a truth, that you can convert something to a different way of narrating it, and it becomes different for that very reason. Like I said, recollecting personal events, they're usually long-term explicit. However, when you come to cultural memories, even if it's historical trauma, those are semantic memories. They didn't happen to us, but in some ways they're part of us. In some ways they've left marks on us and changed us substantially, but nevertheless, you can't recall them in the same kind of way. So a person, the history of a people can't be recollected, even though it's very, very clear that memories like that are stored epigenetically, meaning as part of the genome, are the historical memories that we have. And, you know, if you listen to Jung, there's probably a collective memory as well of us as a race. Of course, it'd be hard to listen to Jung since he's been dead for a couple hundred years. No, probably about 150 years. And then these personal memories, what we will do to hang on to them is often we compose them into a continuous discussion, part of our autobiographical. And like I said, we hang them on the thing we think is ourself in order to be that memory. You don't need to know any of this anatomy, but I'm just saying that memories aren't, you know, in a lot of simplifications of memory, people might say that they're stored in the hippocampus. They're probably not. They're stored in multiple places, depending on what kind of memory they are, whether they have emotional content, whether they have visual or auditory content. All of that is going to differ somehow in the storage. So all you need to know is there's not one place for memory storage. You know, you can't get a brain injury and have your entire life wiped out. Although, yes, you could have that happen, but it isn't because it just destroyed your memory. Implicit memories, like I said, are motor memories, like riding a bike. So they're stored in motor areas. And working memory, the memory where we're doing what we're doing now, attending to the last thing that was said, thinking about, you know, what questions you might have on the basis of that, that's more prefrontal cortex. And that's really all the anatomy that's really important for these. Unpleasant memories are memories that have a strong negative or unpleasant quality, emotional quality attached to them. And they could be, you know, tinged with great sadness or maybe humiliation or things that have happened to us, losses that have happened to us, but they're still memories. That's my point. They are strengthened, and we'll see that in a second. Those memories are somehow indelibly imprinted on us sometimes when they occur. But they're still not post-traumatic memories. They're not flashback quality, which is another category altogether. But they are intensely embedded, and they're oftentimes directly connected to the emotional quality that goes with them, as we all know. Not all those are, you know, episodic memories. Those are, and we always talk about how certain music, certain smells will bring back all sorts of experiences to us. Those are also memories, and they are these emotional memories. All these memories, emotional memories, even if they're unpleasant, can still be narrated like regular memories. But one of the things that they know strengthens the storage, at least, as well as the retrieval of memories, is strong emotion. And usually that strong emotion is communicated at the cellular level by, you know, by activating neurotransmitters, things like epinephrine or adrenaline, as we know it, or noradrenaline, or dopamine, those kinds of things, which are activating. Those seem to intensify the storage of those memories, and it makes sense, you know, that would happen. As an animal in the world, we know certain things we need to avoid. And so fear makes those memories more intense and more charged as well. That's called the memory enhancement effect. I think that, you know, well, I'll just say this last thing and then I'll comment on it. Research has shown, they have done research where direct injections of stress hormones like cortisol or epinephrine, they increase the memory of recent experiences. That's one thing they've tried to work with post-traumatic memories, is administering medicines that counter that effect. It hasn't been particularly successful, but it's an ongoing discussion. I think a lot of students think that if they take medicines that are filled with activating neurotransmitters like Adderall and Ritalin, we've all been, well, maybe not all, I don't know. You probably have led better lives than I have, but nevertheless, you expect that if you take those, you're going to remember things better, and there's some truth to that. There is some truth that something like Adderall and or stimulants in general can intensify those memories, but the effect on actual long-term memory is not as good as we dream. It has more of an effect on our sense of ourselves, So you're sitting there, you've taken, in the old days with Benzedrine, and in the new days would be Adderall or Ritalin. You're taking that and you're thinking, I'm really studying hard. I'm remembering everything. I've never studied this long in my life. Maybe I'm a genius. And you see that those activating memories and those activating stimulants are having much more effect on your mood and the quality of your experience, but don't have as much effect on your long-time retention. That's why students do much better consolidating their memories with some sleep before finals instead of more stimulants. It is true, though, even though emotional intensity does increase the memory, learning under continuous stress, which is basically a toxic internal environment. Learning under that kind of condition actually impairs your memory, and it's hard on your neurons. And so stress, that kind of activating neurons, the ongoing kind, is probably a real enemy of memory. Now, post-traumatic memories. I'm a little over my time here, but I'm going to wrap this in a minute. Post-traumatic memories. When a person experiences something that overwhelms, which is the way, Van der Kolk and most people define a traumatic experience, something that overwhelms your capacity for managing it, categorizing it, putting it in a container and storing it like that. When those kind of memories happen, and the event is so threatening or emotionally intolerable, that memory is stored differently. And it doesn't go into the same category. They don't really know how it does, but we know that it's a different kind of memory. We know one thing, that those memories are fragmented. It's like a flicker. It's oftentimes a flickering kind of memory. Not always, but when that flickering may be due to partial dissociation, because when you're in an experience that's so emotionally overwhelming, you do dissociate with it. You go out, you go somewhere else. I'll just put it that way. And so that affects the narration, the seamless kind of recollection of events. And it has the other thing that traumatic memories have is they improve memory for the central core events, but they impede memory for peripheral events like context. Therefore, lawyers for the defense oftentimes, will use that to their advantage, especially with children, it's true, who tend to remember central items and not context very well. So they might say, yes, this happened. I know this happened to me, but then they under cross-examination, they might be asked, well, what time of day was it? Well, I don't know. And where were you? I'm not sure. And so it looks like it's a fallible or a made up memory, which of course it's not. That memory is probably more accurate and more true for the central items, and yet it lacks context, which is one of the events that occurs when people dissociate. Like I said, they're not inaccurate, And they also don't degrade. Memory tends to degrade a lot of times. Flashbacks don't degrade like other memory. They're just as crisp, unfortunately, today as they were at the time they happened. There was this long study, I'll tell you about this briefly, but they took people who had been in World War II, different combat troops. Some of them had PTSD, some of them didn't. The ones that didn't, when they're recollecting non-emotional kinds of information, that their memory had degraded, had changed over time. In the same way that we do, you tell a story about what happened one time, at Thanksgiving with your family, whether it's a joke or not. And by retelling it, you tend to add things, subtract things, and it alters over time. Flashbacks don't do that. These war veterans recall their experiences that were just as vibrant now as they were in the day that they experienced them. They're also not recollected like normal memories. We don't think and scratch our heads and try to recall them. They're re-experienced, which is the criteria for PTSD, basically. It's a re-experiencing, whether it's in nightmares or flashbacks. It's as though they're actually occurring at the time, which is a kind of dissociation, because flashbacks are a dissociative event themselves. And it means that you feel like you're back there at that time. It's not a recollection like a narrative, if you know what I mean. I think I'll leave it like that. Post-traumatic memories, because they're retrieved like that, are very unpleasant, and therefore we avoid them. We avoid them like toxic events. We avoid remembering them, and individuals with actual PTSD will go to great lengths to avoid having those memories, and therefore, because there's other triggers that remind you, they may go to great lengths to avoid the triggers for those memories. And so it sort of shrinks their life and their experience. There's very little reason, unless you're doing therapy, any kind of history taking that we're doing for the purposes of a psychosocial history or even a diagnosis, there's no purpose to really bringing back those post-traumatic memories. There's no benefit to it in that context. There might be benefit in a therapeutic context. And like I said, memories will degrade. I don't need to perseverate on that, but the more a story is told and verbalized, the less it is remembered. The less, how can I say, true to the event probably it is remembered. What you begin to remember is you're retelling it. And also the other thing that happens, remember I said you can't really, children oftentimes don't remember things. They don't remember things for their significance because they don't understand what was happening at the time. Therefore, they remember theirs. And then later, you come to realize, like, oh, like I saw mommy kissing Santa Claus. That could be a very alarming event when you're 4. It causes a reassessment of mommy, of Santa Claus, and but then you come to realize, like, oh, daddy is Santa Claus. And so everything falls into place. That alters your memory. Basically, you can remember that you misremember it sometimes. Every time you bring a memory up, like I said, you have to reconsolidate it and put it back in. That can be a therapeutic event. That's what I don't think it's easy to go back into that. But that very fact that every time you remember it has to be mobilized, destabilized, and then reconsolidated. That is a therapeutic possibility. That's an edge that you can use to reframe those memories. And it's the fact that a person doesn't remember post-traumatic memories, that's part of what keeps them unchanged. Now, taking a trauma history. This is just some advice, and maybe it's some, from long experience and course style. And, you eventually learn something if you hang out long enough. And so in taking a trauma history, regardless of the reason, we'll go into the reasons why you might, but at the very outset, tread lightly. Even if this is a short question, like a clinic visit for a pediatrician or something like that, don't begin taking a trauma history until some rapport and comfort, mutual respect has been established. I always think it's a bad idea to read trauma history questions verbatim from a questionnaire. I just think it's a bad idea, frankly. If you have to use a list of questions because you're supposed to fulfill this questionnaire, then in some sense, memorize them, humanize them, but just reading them off a list, you may not traumatize the person, but you're not going to get clear information. The state does this thing, all the states actually do this thing called the BRFSS, that it's a trauma history that's delivered over the phone, where they look at rates of trauma in the general population. I think it's a good thing that they do it, but they're not getting accurate history. When someone calls you up and you don't know them and you're on the phone and they're asking you, were you ever abused as a child, you're unlikely to get fully accurate information. It's the same way with questionnaires. Be cautious when you do that. And so it should be part of a conversation, not a script. Because people are very sensitive to being scripted. They like people who think of them as a person, not a data point. And abilide direct trauma-related questions like, were you abused? There's many other ways of asking to talk about it, probably right now. The best way to get a trauma history, I realize, certain kinds of clinicians are not afforded a great deal of time. Certainly medical doctors are not really trying to get this history, but it should be eased into, like a trauma history should be part of a general history. It should be part of your family history. It should be part of your childhood history. And then it will emerge in the course of that. It's always good to balance those kind of fact questions with value questions. And those could be, did you think of your family as a happy family? You realize that's like a Rorschach, meaning it's asking you to fill in the blanks on that. That's a very ambiguous statement. You don't know what happy means. And same thing, was there a happiest time of your childhood? It gives the in my case, patient, in your case, client, a chance to reflect and put value onto their life experiences. One question that I used a lot in juvenile justice was, how were you disciplined as a child? In juvenile justice, as we'll see in a minute, well over 90% of them have histories of abuse and neglect, which is very often why they're in the juvenile justice system to begin with. And so kind of know the answer, but to get the most interesting answers to that, usually it's, well, my parents would take away privileges, but if I was really bad, my dad would get out the belt, but it was only if I needed it. All these values come streaming out. So it's a very good question. How were you disciplined as a child is a good way. It brings back all the feelings that you experienced. In general, though, it's very seldom a memory question. When you're doing a trauma history, or when you're getting into traumatic kind of events in a person's history, it's very seldom a question of memory. People can remember these things for the most part. It's a matter of whether they want to disclose it first, and the skill and the comfort that the interviewer is able to exhibit. So if you never get information like that, I've had kids come into juvenile justice who had all kinds of abuse that they were willing to talk about, and they would say, and I realized halfway through reading their histories, that no one had even asked them certain questions. They never had a chance to share it. So it's a matter of creating the context in which disclosure can take place. Certain information you don't need to know. Like I said, you don't need the full post-traumatic event unless you're doing therapy. Sometimes you just need to know that it happened. And it's a difference between knowing that something happened as opposed to knowing exactly what happened. If you need to know the what, meaning if you need to know what happened here, can you narrate the events of this? You're getting into the area of post-traumatic memories, which you really probably don't want to be in. Not because you're afraid that things will go south on you, but just because unless you're going to do something with it, you probably don't need those memories. If you are going to find out the what, like the details of what happened, it takes a lot more investment, a lot more time. And then finally, draw conclusions from the facts that you already have. If you have a psychosocial, and it tells you something like this child grew up with their grandparents, well, what conclusion do you draw? The conclusion I draw, and it's, of course, you got to remember who I deal with, but the conclusion I usually draw is that something was wrong with the parents or the experience of the parents or their ability to parent. And then you can ask value questions about both that and their other. Was it a good place to grow up? You realize that those are conversational questions. Those are personal questions. The questionnaire kind of questions are basically, give me the facts. And the facts are not where the money is in this. And then asking questions that are non-pejorative about the parents. Was it hard for your parents to take care of you sometimes? I think that's essential to ask, because that is part of the story, They're part, and regardless of how badly it might have gone, they love their parents. And they feel like that's part of them. And so all of this is critically sensitive material. And the more sensitive you are, the better off you are. If you've got a piece of history, like that a child was in CYFT custody, think if there's anything else you need to know about that. There probably is, but you already know that for some reason, this child has experienced some sort of early bad experience in the family setting. And then secondly, that they were separated from those caretakers, two of the biggest traumas that can happen in a child's life. So the history that you already have is critical. And maybe there are some places you don't even need to go. Now, for the sake of time, what I'm going to say is that the reason I'm talking about these discussions in juvenile justice is because it was kind of the perfect opportunity to take a trauma history. And that's where we found out that there was so much more trauma in juveniles' lives than was ever disclosed. I say fewer than half disclose their abuse when they're directly asked during the admission evaluation. But you have to remember how those evaluations, took place. There were multiples. They would see, the psychiatrist, me, they would see a psychologist, they would talk to some of the diagnosticians, they would talk to the teachers, they would talk to medical, and each of them is taking their own viewpoint, their own perspective on what that child's life is. It's the ideal way to gather a trauma history. And the other thing is that, frankly, these are kids who are going to be incarcerated for a while. And so you had all the time in the world. You could say, let's not even talk about that today. We've got plenty of time. Let's talk about it later. You don't always get those advantages. You can't incarcerate everybody that you want to get a good history from. But if you could, if you had that much time, it would be worth it. It really would. So they disclose over time too. You find out things as you get to know them. And what we found out, basically, I'm not going to go into it, but that almost 60% of those kids had 6 or more ACEs, adverse childhood experiences, which is a toxic level, which is very much to the point of how they ended up in the juvenile system. And like I said, the reason we got so much is you have time, you have multiple interviewers, you have facts. And I don't mean family automated client tracking system, the CYFD information system. I mean, you had factual histories of these children. And so you could compare, you know, if a child said, you know, that I had a great childhood, but you know that they were in custody and there were multiple calls to the home, you know that there were troubles there. But you don't, it's not a matter for confrontation, it's a matter of realizing that neither you nor me nor anyone is going to talk about unpleasant or frightening events without knowing a person and without thinking that person in some sense cares about them. So what we learned is that there is always more. That is kind of an amazing fact. There's always more to know about a person. These are not forensic interviews. Forensic interviews are the ones that I'm talking about that happen in a safe house. Your interview is not a forensic interview, and those are done by people that are trained. They do videotape interviews and they're supervised. It's a very high quality interview. It's not that they're perfect, because there are times when they're not, but nevertheless, it's a standardized procedure. And if you look at the research, what it basically says, you know, what this one researcher said, her name was Fallon, and she wrote the book on sexual abuse interviewing. She basically called it the milk and cookies approach, that if you establish a comfortable, friendly, supportive environment that is non-threatening and you take your time, people talk more. They just do. And interviewers with personal warmth, interviewers who asked open-ended questions, and interviewers who take no for an answer, like, no, I don't know what you're talking about. Those kind of interviewers get better histories. All I'll say on this is there's a lot of research on this. There has been a lot of research on this. And we know that a good environment and a good experience with a person is important, but we don't always know who children trust, if you know what I mean. It could have a lot to do with their own implicit memories, their own unconscious memories of various people. It could be, in fact, very fact you're a male or a female. We don't always know who children trust, and so it has to be, it's on the spot rapport is what it is. And this original ACE study found that there was almost a 4.5 increase in deficits in autobiographical memory, meaning people that have very traumatic experiences or childhoods, they will have gaps in their memory. And those are there for a reason. You know, they're protecting themselves and they're protecting everything. And, you know, remembering everything isn't always the best. I know I shouldn't be saying that, but there's some things that are just as well buried. Okay. All I'm going to say about this last part, and you'll have it on the slides. I'm looking at my time, which is, should I end exactly at 1, or should you tell me, Camille, where I'm headed?
We can do a quick check-in at 1, but you have until 1:15.
Okay, good. Well, all I'm going to say is that there is resistance to disclosure. It's a whole topic in itself. That, you know, we know that only 10% of the abuse that happens ever gets reported to, certainly the authorities, or usually to anybody. But we also know that which is remembered, there was a whole effort called false memory recovery, which was intended to discount or somehow disenfranchise the people who are remembering that. That also doesn't happen. very little of it gets reported, and almost none of it gets reported at the encouragement of the therapist. That whole movement was initiated on the basis of a couple of horrific mistakes. One of them being the McMartin case. But then there was also cases where individuals, powerful individuals, were accused of their children of abuse. And they basically went to the mat and created what they call a false memory syndrome, which unfortunately doesn't even exist. And this is the last thing I'm going to say on this disclosure. There's a lot of slides here on, and then we can check in, like Camille suggests. But with regard to allegations of abuse and substantiation, it's very important to understand how that goes down. They did this one study. It's a long time ago, but I guarantee you it is just about the same today. They looked at almost 600 cases of sexual abuse, and 47 of those were determined to be unfounded by legal and child protective services. But when they went back and reviewed all the evidence, the researchers did, there was really only 8% were judged to be inaccurate. 92% were judged to have actually occurred. But it's important, and it's the same thing now. Child protective services will, they don't accept every report. They screen some out at the beginning. It's not their fault, by the way. This has to be this way in some sense. They have to screen out ones which they're not going to be able to do anything about or investigate. Then secondly, even if they get investigated, they probably substantiate about a third of those. Now, does that mean, and this is across the country, not just here, it's here, true. Does that mean they didn't happen if they're not substantiated? No, it does not mean that at all. In fact, we know probably 92% or maybe even 99% of them in some form or fashion did happen. But that doesn't mean it can be proved. That doesn't mean that it needs to be proved. That doesn't mean that prosecution needs to happen or even could happen based upon the evidence. So substantiation is in some ways an assessment of will this stand up in court. And then the rest of these slides are all about disclosure resistance and the fact that we have absented certain kinds of events from our memory, partly because it's not pertinent where we are, and partly because it might be nobody's business, partly because we don't feel like talking about it. It's the same way, you know, not one of us goes through a day where we fully disclose everything we're thinking. Thank goodness. So I'm gonna do that check-in that you suggested, Camille, and then see, and then I'll show a few more slides if there's no real questions to be here. And are we looking at the chat or are we looking at people's actual voice questions?
There wasn't any questions in the chat. There is the survey and the link for the CLEs if you need to get off before we finish. And so I kept an eye on the chat for you.
So should I proceed, Camille and Kristen? Should I go ahead and discuss the last few of these slides? All
Absolutely.
of which have to do. You would?
Yes, I'll keep an eye on the chat if anything pops up.
Okay, just interrupt me.
Okay.
So they look at, they did this one study. Again, these are old studies, but these things have not changed, by the way. I've looked at newer studies, they're kind of duplicates, they're just not as good or as illustrative. So they take a number of people who had sexual abuse history, and they know that it happened because it's there in the hospital records. But 1 in 3, like 30%, failed to recall it when they were just freely recalling their own history, and 12% denied it altogether when they were asked directly, which is, you know, which makes sense based on what I just said. We don't tell everybody everything. But it doesn't mean that that memory is not there. That's my point. If push comes to shove, that memory is there. It's probably partly a emotionally viewed memory. It's probably partly a post-traumatic memory. And they looked at these studies where they were previously documented abuse after a 20-year lapse. They showed just about the same. About a third of the people would not recollect it, and 12% would deny it altogether, except for men who appear to be, much more resistant to remembering certain kinds of men. We've always known that denial in men has never been studied. We know that it is our most effective, defense against anything unpleasant. I can say that being a man, but you know what I mean. You can get away with a lot when you are a member of the group you're talking about. There was another one where they looked at 18% denial rate, like that, close to a fifth of adolescents who had previously documented abuse. But of those who did correctly recall, 72% were accurately reported. Again, it's not a matter of memory. It's a matter of what a person wants to disclose, and it's a matter of the situation, the skill of the interviewer, the sensitivity, and the use of that information. Notice when they did the ACE study, Adverse Childhood Experience study, that was based on adults' recollection of their childhood. But they did that in a particular kind of way where the person was able to complete that information without, it was de-identified for one, and it was not in an interview, it was done over time. And so it allowed disclosure. It didn't provoke it, or it didn't create it. Physical abuse, harder to track. But they revealed that 40% of the men and women failed to report it retrospectively, partly because in the delinquent population, in the juvenile population, there's no clear definition of what physical abuse means. I mean, families are very different. And even though I think of using the belt as, as a violation of abuse, this has been a lot of these things have been normalized for children. And therefore they don't report it as abuse because they don't think of it as abuse. It's one of those cases where you don't recognize what you don't know. But they do, it isn't that their memory is impaired, because when you're asked about other questions, they always report like moderate aggression, like fights with their brother, or or a yelling match or something like that. I'm going to skip a couple of these. Victims less than 7 at the time of the disclosure, at the time of the event, the abuse event, they were less likely to recall that incident years later. Victimization by relatives was less likely to be called substantially because it's emotionally laden. Its value content is too tense and too unpleasant to necessarily remember. And it's also true that children who receive more maternal support, this was a way to study, but it would work with fathers too, by the way. But children who receive more parental support are much more able to correctly recall an incident later. It is the cardinal rule of trauma, is children who are treated with great care and concern after an event recuperate better. That's the hallmark of all traumatic experiences. And children with secure attachments also have better memory performance about previous events. So the overall picture is that from all the literature that you can look at, and you should look at it yourself if you're interested in this topic. I think this is the most interesting topic, not just for legal questions, but for all of us in our lives. The general picture is that the core of both non-abusive childhood traumas and child maltreatment tends to be remembered pretty accurately. After delays, maybe as long as years, maybe as long as decades, unless those events were experienced in the first 2 or 3 years of life, in which case they're stored as unconscious memories, probably. Some people say they remember being born. I don't, and I'd like to talk further with those, but nevertheless, for the most part, anything that happens after 2 or 3 can be remembered. It's all a matter of whether we need to know it and how sensitive we go about it. So I think I'll stop there. And if there are any questions.
Chester, it looked like you had made a comment, but I'll let you ask it. Or is it something that you're asking, like how to phrase that? I don't know if he's still on. So he put in the chat box, I couldn't form a memory of my question, but now I have it, put it in words. So a good thing. Chester, do you want to elaborate a little bit?
What that means. I will say, just to say a couple more things before we end up closing this off, that a lot of us take this information is not new. It's not part of a regular history.
Terrence, can you unmute yourself, please?
Wow. Terrence, you did something I've never seen before. There's 2 of you here, and both of you are operating. So what I was going to say, this kind of information, like a trauma history, is essential, not just for therapists, not just for the legal community. It's essential really for the medical community, too, because as we know from the adverse childhood experience study, like early trauma is associated with everything from drug abuse to later suicide to physical things like autoimmune disorders, heart disease, all sorts of physical. In fact, most physical diseases can in some way be linked to early kinds of trauma. And so the pediatrician and the internist who takes a history does have an interest in knowing these things. And usually it's the interest of that it happened. We need to know that it happened. And because it explains something, it's an essential part of a medical history. If it can't be gathered, then it can't be gathered. But everyone has a little bit of an interest, and we as patients and as well as clinicians have an interest in telling a certain amount of that history to the people that are seeing us as patients. Any other questions or contradictions? Those are open too, because this is controversial material.
Dr. Davis, and this is just something out of my own curiosity, but is there any correlation to the grooming process in regards to disclosures and the effect of the grooming process on disclosures?
Grooming, you say?
Yeah, the grooming process where the perpetrator.
Yeah, it is, and but it is a very complicated topic. Meaning that grooming process can be normalizing. But oftentimes, that's not the only problem. And oftentimes it is the same person who loves you and who has expressed care for you might be the person that abuses. And that adds a tremendous twist to the whole memory. You know what I mean? It's not oftentimes not remembered as a post-traumatic memory because the event itself wasn't overwhelming. It's the influence later, but it's oftentimes, yeah, it does. It complicates it and enormously affects the evaluation of the experience as well. There might be people on here. Possibly one of them is Susan, who knows that answer as well as I do. I imagine there are therapists on here, which last time when we did this at CLI, it was they were waiting in ambush.
I'm not sure if that was an invitation for me to say something or just for me to laugh. So
No, you can use it as an opening in any way you want to.
No, I just agree. I think that the issue of the familial, the one who loves me does this. There's, well, I don't know. I actually want to use the word evil, but evil doesn't really fit in the legal definition. But there's something, there's insidious and horrible and really horrible and unbelievably horrible. And there's always going to be that gradation of who does what to whom. So the closer the relationship, obviously, hopefully. No, it isn't no guarantee that isn't. So, okay. Well, anyway, I think I'll stop there. I think we're finishing up, and I'll stop with that comment.
Yeah. Well, that's why value questions like what was the happiest time of your life are so important, because we realize there's all sorts of mixed things, like that a memory of a Christmas that was particularly sweet might have a traumatic memory embedded in it. That's the complication right there. Everything we evaluate constantly, but it never falls neatly into boxes or categories.
Yeah, I would say, but especially that just thing you just said, a good memory may have something embedded that was not good. In a familial situation, other siblings don't share the bad part. They may not be present for that or have that happen to them. And so it's dismissive to the child who did have the negative experience within the good experience. And so there's all these alienating, isolating kinds of things.
Absolutely. In fact, if you want to cause conflict at your upcoming Thanksgiving, ask your siblings at the table, how was your childhood? And you would not believe the different evaluations, traumatic or not always traumatic, but the different evaluations, because those experiences with your parents are unilateral. Also,
the death of that parent is a big place where that stuff goes on.
Yeah.
Thank you, Doctor.
Yeah, it's a pleasure.
All right. Well, thank you, Dr. Davis, for this invaluable information and very important in the practice that we do. Appreciate you taking the time to come and share it with us. And for Kristen, I don't know how much arm twisting she had to do, but to Kristen for finding you for us too.
Very, very little.
Good.
He's pretty cooperative.
Compliant, I think is the word.
Yeah, that's it.
There you go. There you go. Well, thank you everyone for coming. We will resume our external echoes in February and topics to be determined. So in your evaluation, if you have some topics that you would like to see in February, let us know. January, we have our internal echo, and then in January is CLI. So that's why the not till February piece. All right. Well, thank you, everyone, and have a good day.